gynecologist and nurse for S. Wilson Educators, and today I'm going to be talking to my pink sisters, those of you that have been diagnosed with breast cancer. Now, getting diagnosed with breast cancer is never an easy thing to do, but you're going to have to make some decisions pretty soon on some options that you may have to choose. Now, some women are going to choose lumpectomy. This is recommended a lot of times either for a small tumor or a tumor that they're going to shrink down with chemo, radiation, or both, and then get it to the size that they can manage it to do a lumpectomy. And a lumpectomy is simply removing the tumor and some surrounding tissue until the pathologist says that they have what they call clear margins. And sometimes they will take just a little more out. Most of the time, women will emerge from surgery and their breast will not look very much different because the lump has been very, very small. Sometimes, however, you will emerge from surgery and your breast does not look the same. They had to take a lot more tissue out, so you'll have missing spots in your breast. Don't fret if this happens. You can get some things done later on to make that breast look better. Do know, however, if you choose lumpectomy, you will 100% get radiation therapy. And sometimes you have to have chemo as well. And that's going to depend on when they take your tumor out and they test it. They will know more about what you need and what kind of tumor you have. And I'll do a video at another time on determining your treatment of care for different types of tumors. So do be watching for that. Now, the next option is mastectomy, but a mastectomy is removing all the tissue, sometimes removing all the top skin, and sometimes removing the nipples, and sometimes we can save those, and that's on very few people you can save the skin and the nipples, and that's only for people that the tumor is very, very small and very far away from the nipple and the skin area, and it does increase your odds of getting breast cancer again. So is it a risk that you are willing to take is another thing. Now, mastectomy is unilateral or bilateral, and unilateral simply means taking off one, and bilateral means taking off both. Some people will go with the unilateral because of decreased funds. Some people don't have insurance or anything like that, so they can only take off that one. And some people have the idea in their mind that they don't want to take off a healthy breast, so they don't take the other one off. And if this is the way you feel, this is okay. And some people do want to take both of them off, not only to decrease their odds of ever getting cancer in the breast again, but also some people have a bad history like myself, and that's what I chose, was a bilateral mastectomy. And also some people, a matching set is very important, and that was important to me as well. But it is a very personal choice. If you don't have anything going on the other breast, that you can leave it on. Sometimes a doctor will do a reduction of the other breast just so that the breast is not so big on one side if you have a big breast, and then that way they're not so uneven. If you decide on any one of these, there's no right or wrong answers. It is up to you. Do know there's a law on the books since 1998 that says if you have insurance that pays for a mastectomy, they must also pay for your reconstruction. There is a loophole, however, on that opposite breast. They only want to match it for symmetry is the wording. You can get around this somewhat, but do know that. So now some people are going to just stay flat and do no reconstruction. Some people are going to get tattoos on the flat chest just to cover up their scars. Some people will get breast mounds and cover them with pretty tattoos after they have their mounds. And some people will get tattooed nipples after. All of these are things we'll have to discuss in a later video. But for now, we're talking about just the reconstruction part of it. If you want reconstruction, you're going to have to educate yourself, and that's why this video is here, to tell you what is available out there. Now, I'm only going to touch on the most frequently used reconstruction options. First of all, we're going to talk about implants. Now, implants are usually not done at the time of surgery. What will happen is they will go in and do a mastectomy on you, sew you up, and you will put what they call an expander in, and it is actually an empty implant. It has a little valve on it that's magnetized. It goes into your body, and you will emerge from surgery either completely flat or just a little bit of saline solution in that expander. And what this expander does is just what it says, it's starting to expand your skin. And in this case, you will continuously go back to a doctor to get a little more put in and a little more put in and a little more put in until you get to be the cup size that is desired. And this can go on for months. It can go on for years even if you have a very, very small pain tolerance, because you're going to have to tolerate the pain that they're going to do to put the fluid in ever so often. So a lot of that's going to be dependent on how well you tolerate the procedure. And then once they get it to the cup size that they want, they deflate it in another surgery, pull it out, and put in the permanent implant. Now, there are some doctors who do direct to implant, which will mean that they are doing skin sparing on you. They're not taking all your top layer of skin out, and they're putting in a full implant at the time of surgery. This is not done by a lot of doctors because a lot of doctors do not want to save the skin, and also it's not done a lot because if you need radiation, radiation affects the integrity of your skin. So doctors prefer to do the radiation, get the skin back in good working order, and then put the implant in at a later time. But at least I'm telling you what it's called. It's called direct to implant if they do that. Now, the other options out there are called Otakaless, and these are using your own tissue to reconstruct the breast. Now, I'm only going to touch on the most frequent ones out there. And the first one, it's not done real often anymore, but you will hear about it. It's called latissimus dorsi. This is latissimus dorsi muscle, named after that muscle that they're going to use in this procedure. The muscle is used for the blood supply that will keep the tissue alive. They actually will cut through this and pass it through and push it out here, and it still remains attached to the latissimus dorsi as the blood supply. You don't get a lot back here. You're probably not going to have a big breast, but they still do it. Do know in this one, if you are somebody who is very active, like you play tennis a lot and you have right-handed and you have right breast cancer and you love to play tennis every day, you're going to have a compromised state here. This may be the one you don't want to do if you are concerned about that. The next one is called Scap and I-gap. They are the same procedures as taken from a different place. Scap is superior, I-gap is inferior, and both of them stand for gluteal artery perforator. So this is the perforator is the artery that they're going to use. Now, do know, ladies, that again you have to have a big badonkadonk if you want to do this one, because you don't want to be flattening out your buttocks. So if you have a big area here and you want to get rid of some of it, that's a good option for you, and both of them use the gluteal artery from there. The next one is called Tram, and Tram is done one of three ways. The first one is the attached Tram, and by the way, Tram stands for transverse rectus abdominis mycutaneous. You've all heard of the six-pack muscle. It's your abdominal muscle, okay? That is the abdominis muscle. And it is using a part of your muscle to keep the tissue alive. And in tram flap procedure, you can have the attached tram flap, which uses the skin, the fat, and the underlying muscle, and it's tunneled underneath, and it comes out from your breast like this. The next one is the free tram. It's the same as the other one, except that they take part of the muscle and free it somewhat to do this procedure. The next one is called muscle sparing tram. This one takes a very small part of the muscle, but they actually detach it and use that muscle as the blood supply to keep that alive. This is done more often than the one I'm getting ready to tell you about. The next one I'm going to talk about is DIEP, D-I-E-P. It's called deep inferior epigastric perforator. It's the perforator artery that comes from deep down into your abdomen. It is the newest surgery. It is the most complicated surgery. It is microsurgery. They do not harvest any muscle. It is the one that I chose, but you have to be in good health because it is a very long surgery. Mine was 9 hours long. And also you have to be somebody who doesn't smoke, because smoking constricts the vessels down, and they're going to use a vessel here and a vessel here and attach the two of them, called anastomosis, and you can't let it kink off in any kind of way because that's your blood supply, and if you kink it off, your tissue can die. So be aware of that. No smokers with this one. And also with this one, you have to be a person who has never had liposuction, maybe never had an abdominoplasty, which is a tummy tuck, and they're going to do some tests first before they do this one to make sure that that perforator artery is a good artery and it's going to be able to sustain the tissue. So this one is going to result in a tummy tuck per se, because you're going to have a flatter belly. Some doctors will cut you straight across. I prefer the method where they cut you a little bit on an angle, because since I have a flat belly now and my incision healed very, very good and very, very small, if I choose to, I can wear a string bikini because it's hidden by that. Do know that they're going to be cutting you from hip to hip. It is a very extensive opening. Your belly button may look a little different when they're finished because things have to be kind of rearranged after they do this surgery. If you choose this surgery, you're going to have to look for your doctor very carefully. There are not a lot of doctors in the United States that do this surgery. Definitely not going to probably have them in a very small town, so you're going to have to be willing to travel. Mine was done in New Orleans, Louisiana, where I had great results. Do know also with this one that you're going to have to scout your doctor out very well and find out how many of these surgeries has he done, how long has he been doing the surgery, and see some pictures for sure of his finished results. I want on all of these procedures to be able to see pictures of the doctor's work, because not everybody is the artist, not everybody does great work, and if he can't show you pictures, he might not be proud of his work. So if there are several doctors in the practice and the website has pictures, ask this particular doctor that you are interviewing which one of these patients has he done, and if he doesn't have any of them on the website, he may not do good work. So you need to see his personal pictures, not just the pictures that are on the website. I hope that this has helped you to make a good decision of what is right for you. Not every procedure you will be a candidate for, but what I like to tell my people in my lectures is pick the one that you want first, second, third, fourth, fifth, and go down the line, because you need to be able to be a candidate for the particular procedure that you're picking, and educate yourself on the terminology of where they're taking it, how big your scar is going to be, and etc. Most of the time they have to cut you across here, and they're going to make you flat and also take the nipple, so they take it from here. But do know that some doctors will cut you from way back here to all the way here. It's not the preferred method in my opinion. The smaller the incision, the better, and the better you will look later. So you have to ask these questions, ladies, so that you know what you're getting yourself into as they remodel your breast. Now, I hope this has helped you. Do know that it takes a lot to produce a video of this nature, so I would like you, please, 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 to press that subscribe button and that like button. It keeps me motivated and keeps me wanting to make more videos, especially for breast cancer survivors. So don't forget, press that like button down there. Thank you all for watching. This is Cheryl Wilson, registered nurse for S. Wilson Educators. Bye-bye.